Good morning. For the moment, we are discussing differentiation between skew deviation versus superior oblique palsy. Although clinically it is not very difficult to identify superior oblique palsy because of the head tilt, which is to the opposite side. The nine extraocular movements, that is, extraocular movements in nine cardinal positions, is important while doing oculomotor examination. And as you can see that when the patient sees to his right and down, the left eye is hyperdeviated, that is, it is at a higher level as compared to the right eye. So it is likely to be the left superior oblique palsy. However, we need to differentiate between this from the skew deviation. This is the alternate cover test. We are doing it in the upright position. Left eye goes down very less. The right goes up. Going up of the right eye is very prominent. The head tilt to the right is very well evident. So we do a test called Parks-Bielschowsky three-step test. There are first step is which eye is hypertropic in the primary gaze. As you can see from the figure at the right of your screen, the left eye is hypertropic. So if the left eye is hyperdeviated in primary gaze, the muscle that is paretic is either responsible for pulling the left eye down or for the those pulling the right eye up. So therefore our suspects in the left eye are left inferior rectus or left superior oblique. In the right eye, the right superior rectus or right inferior oblique are suspects. We can eliminate all other possibilities. The opposite is true if the right eye is hyperdeviated in the primary gaze. So we just circle the left superior oblique and left inferior rectus and right superior oblique and right inferior oblique on our drawing without having to think about the other actions. So step 2 is vertical deviation greater in the right or left gaze. As you can see from the two figures on the right of your screen, the vertical deviation of the left eye is greater on gaze to the right. The deviation, because it is greater in the right, this implies that the paretic muscle must be either one of the muscles whose primary action is elevating the right eye on the right gaze, or one of the muscles whose primary action is depressing the left eye on right gaze. The right superior oblique and left inferior oblique both have a primary action of elevating the eye in the right gaze, and the right inferior rectus and left superior oblique both have a primary action of depression in the right gaze. The opposite is true if the deviation is greater in the left gaze. So simply circle the muscles on the right if the deviation is greater in the right gaze, or the muscles on the left of your drawing if the deviation is greater in the left gaze. It is right here. So we have now encircled with the right superior oblique and right inferior rectus, left inferior oblique and left superior oblique. So the third is looking if the vertical deviation is greater in the right or left gaze. As we can see that the vertical deviation is greater when the head is tilted to the left. When the patient's head is tilted to the left, the right eye needs to turn outwards, that is, needs excyclotorsion, and the left eye needs to turn inward, that is, encyclotorsion. The muscles responsible for this action are right inferior oblique and right inferior rectus, and left superior rectus and left superior oblique. If any of these muscles could be paretic muscles, the opposite is true if the hyperdeviation is greater with the right head tilt. So we have encircled these muscles, that is the right inferior oblique and right inferior rectus, left superior rectus and left superior oblique with the green. So the muscle that is consistently involved in all our three tests is the left superior oblique, and this confirms that this patient suffers from left superior oblique palsy. There is one other way of testing as we are doing here, that we have shown in the diagram, the extraocular movements in 9 cardinal directions, the three we have seen here. So as the gaze is shifted to the patient's right and down, you can see a greater hyperdeviation, that is the left eye is hyperdeviated, and therefore the left superior oblique is paretic. Again, in this position, the left eye is hyperdeviated, indicating left superior oblique palsy. So another thing to do is doing alternate cover test in sitting position as well as in the lying position, because in lying supine the gravito-inertial vectors are significantly eliminated. Therefore, in skew deviation, the deviation will markedly diminish in the when it is done in the supine position. So let's see here again. The right eye goes up much more than the left eye going down. So we'll compare the movement of the right eye with that when the patient is in supine position. We'll see only focus on the right eye. This goes up, this goes up. So differentiating cranial nerve palsy fourth from skew deviation, hypertropia in primary gaze is present in both trochlear nerve palsy and skew deviation. Committance, that fourth cranial nerve palsy is incommittent. Hypertropia worse on gaze to the opposite side acutely may become committent with the time. In skew deviation, it may be incommittent, committent, or alternating. Effect of head tilt on hypertropia. Hypertropia worse on ipsilateral head tilt in trochlear nerve palsy. Hypertropia may or may not change with the head tilt in skew deviation. Lateralization of the head tilt in respect of hypertropic eye. The compensatory head tilt contralateral to the hypertropic eye in trochlear nerve palsy. In skew deviation, pathologic head tilt is contralateral to the hypertropic eye. Direction of torsion of the hypertropic eye. In the trochlear nerve palsy, the eye is having excyclotorsion of the hypertropic eye, while in the skew deviation, there is encyclotorsion of the hypertropic eye. Associated neurological signs in fourth cranial nerve palsy, there are no other neurological signs unless caused by brain trauma or lesions in the brainstem. In the skew deviation, usually has other neurological signs like gaze evoked nystagmus, that is bidirectional gaze evoked nystagmus, gaze palsy, dysarthria, ataxia, hemiplegia. Upright supine test is very important. In trochlear nerve palsy, it is negative. If that we have seen in our earlier two slides, a vertical strabismus that decreases by more than 50% from the upright to supine position is 100% specific for the skew deviation. So algorithm for pathological OTR, but to rule out Dissociated vertical diversion. Dissociated vertical diversion doesn't follow the rule. In patient with congenital strabismus, unequal binocular visual input exerts the same physiological effect as unbalanced utricular input, producing a combined vertical divergence and cyclotorsion of the eyes. In DVD, however, the cycloversion movement is opposite in direction to that seen in the utricular tilt reaction. So, vertical strabismus, here you see rule out DVD and pseudo strabismus, that is ptosis, orbital or facial dysmorphism. Rule out the mechanical restriction and then do a three-step test. If the three-step test is negative, it is suggestive of the weakness of other cyclovertical muscles. Brain MRI with gadolinium is to be done. If the three-step test is positive, which is suggestive of trochlear nerve palsy, upright supine test is done. A positive test indicates more than 50% decrease in the vertical deviation, and in that case, skew deviation is for sure. Brain MRI with gadolinium is required. If it is negative, that is less than 50% decrease in the vertical deviation, and if there are no neurological signs, the trochlear nerve palsy is for sure. If there are other neurological signs, brain MRI with gadolinium is required. So this is decision making for vertical strabismus of acute onset. Thank you very much. I finished my